prevalent wide breast, lung, colorectal, and prostate. And from a number of deaths perspective, it's the third most relevant cancer in terms of mortality. These are numbers from 2020. In the United States, it is the 13th most common tumor type and the 6th commonest cause of death. And while it's only representing about 2.4% of all cancers, the concern has been a gradual increase in the incidence of this cancer over the last couple of decades. And similarly, there is increased mortality associated with this cancer, again seen over the last few decades. In 2020, the estimated number of new cases in the United States was about 42,810, and about 30,000 cases are expected to, they actually died due to liver cancer. The 5-year survival is less than 20%, and hence it remains a major unmet clinical need. Some important facts about hepatocellular cancer. It is a primary liver tumor. It's the most prevalent primary liver tumor. It's sexually dimorphic, occurring about 2 to 3 times more in men than women. And one important aspect of liver cancer is that it doesn't develop in a healthy liver. About more than 90% of the times, there is an underlying chronic liver disease, and these patients have advanced fibrosis or cirrhosis. Occasionally, liver cancer can occur de novo in the background of a relatively healthier liver. And one such instance is of a neoplastic transformation of a benign tumor, hepatocellular adenoma. These hepatocellular adenomas that would progress to liver cancer have been now very well characterized. They are the ones that are carrying a specific mutations and also occur in an inflammatory milieu. But we are not going to discuss too much of that subtype of tumor. Another variant of liver cancer that we are not going to discuss much about today is the fibrolamellar variant, which is very distinct disease. It usually occurs in younger adults who have no prior history of liver disease. And again, there has been a lot of work done in molecular characterization, and in more than 90% of these fibrolamellar variants, there is one particular fusion gene that has been identified to be the driver of this specific tumor type. Hepatocellular cancer is also distinct from hepatoblastoma, which is a pediatric liver tumor. In children, you can get both hepatocellular cancer and hepatoblastoma, and although both are relatively rare, the HCC in pediatric patients also occurs in the setting of chronic liver disease, whereas hepatoblastoma occurs in a relatively healthy liver and is the origin of this tumor is very distinct and is thought to be due to defects in differentiation of liver cells or hepatoblasts, and which are then suspended in specific stages of differentiation and continue to proliferate and lead to this type of a tumor. As I mentioned, hepatocellular cancer typically occurs in the setting of chronic liver disease due to any of these etiologies mentioned here in the left corner box, due to either viral infection, HBV, HCV, due to chronic alcohol-associated liver disease or non-alcoholic fatty liver disease, or other cholangiopathies, etc. The normal liver is undergoing injury, and as a result of this, there is wound healing response, which is the early fibrosis, which then continues to progress if the disease or the injury continues to occur to result eventually in cirrhosis. Cirrhosis is a known risk factor for the development of hepatocellular cancer, and I'll talk about the underlying cellular machinery that leads to HCC and the molecular drivers that lead to HCC in the next forthcoming slides. But what's important is that this chronic insult that eventually leads to hepatocellular cancer can occur over decades. It can take anywhere from 5 to 50 years for liver to undergo this kind of injury, which then eventually results in cirrhosis and liver cancer. And again, as I said, it's a very protracted course, making the relevance of surveillance of patients who are at high risk of this neoplasia to be a very important part of management, because early diagnosis is critical in a disease like this, because the surgical management is really the only precision-based medicine that is available in HCC. And we'll be hearing a lot from Dr. Obaid Sheikh and from Dr. David Geller about those early surveillance and early intervention for therapeutics of liver cancer. So because of that protracted course, the age-based incidence of HCC is evident usually beyond 50 years of age in a patient. So most of HCC is seen in older patients, again, because it is taking a long time for the liver injury to occur and eventually leading to fibrosis and advanced cirrhosis. And just because most HCCs occurs in the backdrop of chronic liver injury, it is a challenge to take care of these patients because you are treating not just one disease, it's not just one tumor, it's also the underlying liver disease. So it's two diseases rolled into one. And hence, when an optimum therapy is identified for a liver cancer patient, it has to take into consideration the underlying liver disease, the stage of that liver disease, the performance of the patient from a liver perspective, as well as the size and the nodularity or the invasive sort of stage of tumor. So just a simple classification does not do the job well to take care of these patients, and hence there have been many different ways these tumors have been classified to provide best care to a liver cancer patient. And this is just an example of BCLC or Barcelona Clinic liver cancer staging, which you're going to be hearing more about in later talks, especially from Dulab as well. So this is probably the most relevant slide, which is going to talk about the cellular mechanisms that are relevant and lead to the development of hepatocellular cancer. So due to any of these pathologies that I mentioned up there, alcoholic liver disease, NASH, and hemochromatosis and cholangiopathies, et cetera, there is chronic insult to the liver. And what I mean by that is that the cells that are injured within the liver are hepatocytes, and which are the major functional cells or functional units of the liver. And what that does is this is a simple tunnel staining on a liver in red, and you can see the cells are dying when they are chronically injured. But as a result of this, the other liver cells or hepatocytes that are present around that dying cell will get a signal from these dying cells to now proliferate so that they can compensate for the lost cell. So there is this bout of liver regeneration that happens when a cell is dying. Because it's a cell death and cell proliferation event, that's what constitutes a wound healing response in the liver, because liver is injured and now it has to be replaced by some scar tissue. And because of this ongoing injury and regeneration, a lot of immune cells, neutrophils, lymphocytes, macrophages are brought into the parenchyma, and stellate cells, which are yet another fibroblast-like cells, which then generate collagen to form a scar in the liver, are activated. There is associated endothelial cell dysfunction, and there is also production of reactive oxygen species in this microenvironment. And this whole sort of cycle of injury, repair, and inflammation, fibrosis happens for many, many years. And eventually, if those cells are proliferating in this very adverse environment, there begins to occur DNA damage in the hepatocytes. And one of those forms of damages is the occurrence of mutations. When some of these mutations occur, if that specific mutation is able to give a survival or a proliferative advantage to a cell, then that cell begins to grow as a clone, as is depicted here on the right, where this green cell has just accumulated a pro-survival mutation because of either an activation of an oncogene or loss of a tumor suppressor. And then this particular clone of cells begins to grow and eventually results in a formation of neoplasia. And once this tumor forms, it continues to progress and becomes more heterogeneous. Rarely, you will find a subset of hepatitis B patients, aflatoxin patients, and even subset of NASH patients, which are going to skip these years of insult, and through some direct DNA integration effects, for example, of hepatitis B, it can directly cause either suppression of some tumor suppressors or mutations in an oncogene to activate this survival pathways, and then you can get the development of liver cancer without any advanced cirrhosis. In other words, you can begin to see neoplastic lesions even when the liver is not fully fibrotic or cirrhotic. So this truly is the cellular basis of HCC. And how does this look like under the microscope? I'll just give you an example of non-alcoholic steatohepatitis, because this is one of the most prevalent disease in the Western world when it comes to the liver, because of obesity or because of other metabolic syndrome associated pathologies. 30% of our population in the Western world has some degree of steatosis, which means there's accumulation of lipid in hepatocytes, which is seen as these clear areas on tissue section. About 10% of these patients are going to progress to NASH, from simple steatosis to non-alcoholic steatohepatitis, which means that in addition to now fat, you're going to begin to see a lot of these immune cells that are present. And this is how we classify the development of non-alcoholic steatohepatitis. And 25% of these NASH patients are going to progress to full-blown cirrhosis. And you can see this here by staining for Sirius red or trichrome, which is a marker of collagen. And you can see these blue areas around the different hepatocytes. And then a subset, about 10 to 25% of these cirrhotics will progress to HCC because this is a clone of cells that have now been able to survive and expand in this very adverse microenvironment. And very rarely you will skip the development of cirrhosis, and a subset of NASH patients are going to evolve into HCC without growing through this. And the molecular mechanisms behind this are still not fully understood. But what has also been very relevant is that there is a slight increase in the incidence of a type of cholangiocarcinoma or bile duct cancer in these NASH patients. And you can see that there is that these patients with NASH are at a slightly higher risk of developing intrahepatic cholangiocarcinoma, which is something that I'm not going to go into detail. So the question then becomes, what are some of the earliest alterations that occur over time that give these clone of cells a survival advantage. And this has been addressed by doing exome sequencing or RNA sequencing on different stages of liver in patients. People have examined healthy liver, cirrhotic liver, low-grade dysplastic nodules, high-grade dysplastic nodules, and eventually hepatocellular carcinoma. And one of the earliest events that is observed in these patients with which show low-grade dysplastic nodule are mutations in TERT promoter. About 5% of the cases have shown TERT promoter mutations, and in a high-grade dysplastic nodule, this incidence is higher. And as soon as you begin to see hepatocellular carcinoma begin to occur, you begin to see additional mutations in genes like beta-catenin, p53, and others. In fact, there are about 40 to 60 mutations that have been observed in hepatocellular carcinoma on average once it's diagnosed. But what is very relevant is that the top 3 genes that are most prevalent in their mutations, the TERT, which encodes for telomerase, p53, and CTNNB1, which encodes for beta-catenin, also have shown a trunk role in liver cancer development. What do we mean by that? It means that these are the mutations that are observed even in the smallest of HCCs, meaning the earliest possible lesions, which kind of give you an indication that these are drivers of liver cancer. Then there are mutations. These are also the mutations that are present in different regions of a large tumor. If you have a larger tumor and if you sample 3 different areas or 4 different areas, if it's a true trunk mutation, it'll be positive in all of those areas. And finally, if you have a multinodular disease or a metastatic disease, if these trunk mutations are commonly present in the primary as well as the metastatic event, or if it's a multinodular disease, the same trunk mutation is present in all different nodules, again indicating that these are really the major drivers of liver cancer. So if you summarize the various mutations in HCC, you can see again that there are all these mutations. The most frequent mutations are TERT promoter mutations, followed by beta-catenin, followed by p53, and then there's smattering of all these different other oncogenes that are known to be mutated, or tumor suppressors that are known to be mutated. And these 3 mutations, TERT, beta-catenin, and p53, again, are the ones that are the most abundant in all liver cancers. So the next question is there any enrichment of mutations based on etiology, on underlying etiology of liver disease? And the answer is, in some cases, yes. For example, when you're looking at hepatitis B virus, there is overrepresentation of mutations in IRF2, in p53, MLL4. If you're looking at alcohol, in alcoholic liver disease-associated HCC, there's overrepresentation of telomerase, there's ARID1A mutations, and also beta-catenin and SMARCA2 mutations. There are no specific enrichments that are observed in HCV, hemochromatosis, or in metabolic syndrome, where, again, the most frequent events continue to be TERT, beta-catenin, and p53, among others. So based on all of these high throughput omics, multi-omics analysis, we have been able to understand the molecular landscape of HCC pretty well. In addition to these mutations, we know that, which genes are frequently deleted or amplified. We know which molecular pathways are activated, and we also know the status of methylomics, or which promoters of the genes are hypermethylated, meaning that their function is suppressed. And this has resulted in our understanding of really what are the major downstream effectors that are controlling the growth and survival of liver cancer. And as you can see, one of the major drivers of this process is the receptor tyrosine kinase, RAS, PI3 kinase pathway. About 20 to 25% of the cancers are showing activation of liver cancer, are showing the activation of this pathway. No wonder some of the first drugs that have been used successfully in treatment treating liver cancer, including sorafenib, lenvatinib, rego, ramo, and cabo, which again you'll be hearing more about later from Dulab, are all targeting this particular area of molecular pathways. However, there are other pathways such as telomerase, p53, Wnt, and certain chromatin modifiers, which are again present in significant subset of liver cancer patients, but unfortunately have not been yet successfully targeted. And there's a lot of ongoing research that is playing an important, that is hopefully going to make relevant progress, and we'll have better therapies in this space. But one thing that is very relevant and worth mentioning is because, again, liver cancer happening in chronic liver injury, there's always a very close relationship of immune cells or inflammatory cells that is observed in HCC. In fact, in this particular study, if you look at the tumor microenvironment, you see these cells, CD3, CD8 lymphocytes, CD20, CD68 macrophages, are always present within this tumor microenvironment. And one of the things that these immune cells do is that they should be there to attack and kill cancer cells. But because they produce these potent cytokines like interleukins and TNFs, et cetera, which are usually known to be cytotoxic. So why then, despite the presence of these immune cells within tumor microenvironment, they have not been able to kill hepatocellular cancer on their own? The question is, do they have these cancer cells develop some type of a defense mechanism against immune cells? And the answer is that is exactly what has happened. There is a very well-defined immune cell evasion that occurs by these cancer cells. And not to belabor too much and go too much into the biology, I would just say that there is upregulation of certain ligands such as PD-L1 on cancer cells, which engage T cells to block their proliferation and inducing their exhaustion. Also, there are others like CTLA4, which can bind to the dendritic cells and then can block the activation of T cells. So there are these maladaptive, rather adaptive mechanisms that these cancer cells have developed that have eventually resulted in immune cells not being able to recognize them and kill them. And for that very reason, has been this major game-changing technologies and modalities that are being used in oncology clinic, and those are the immune checkpoint inhibitors, because these immune checkpoint inhibitors have been able to target these PD-L1s or program death ligand 1 or program direct 1 receptor or CTLA4, and they have now prevented immune cell exhaustion, have altered Treg activity to activate T cells, which can then turn on the cancer cells to kill them. And indeed, that's been the basis of why there has been very successful use of immune checkpoint inhibitors in HCC treatment. And again, I think Dulab is going to talk a lot about medical therapy, but these are just some of the example: nivolumab, pembro, and most recently, a combination of atezo-bev, which has attained objective response rates of about 30% and really unheard complete responses in about 7 to 8% of all liver cancer patients. And more data is coming almost every few months on some of these clinical trials. But there is high likelihood, in my opinion, that these objective response rates would not exceed beyond a certain level unless we understand more the biology of cancer cells and then try to be very careful in selecting the right subset of liver cancer patients who may respond better. And just a couple slides on that. One of the mechanisms or pathways that has been shown to drive immune cell evasion is the Wnt beta-catenin pathway, which, as I've mentioned, is seen to be active in about 25% of liver cancer patients. And this is just an example of how, if beta-catenin is mutated in the cancer, you see it as a nuclear translocation. And if you look at these liver cancer, you see very few CD8 positive cells in the tumor microenvironment. So beta-catenin mutated cancers actually prevent immune cells from even being infiltrating into the tumor. So they almost form like a shield of some sort. So these tumors are really immune desert. And that's the reason why if you use an anti-PD-1 in a beta-catenin mutated cancer, you see no tumor survival benefit. Whereas if you treat anti-PD-1 with, if you treat cancers that are driven by a non-beta-catenin dependent signals, for example, in this case, it was a P53 loss and MYC-driven cancer. These tumors respond very well to anti-PD-1. And this is also seen in patients where there's always overrepresentation of beta-catenin mutated patients in the non-responders. So I think learning about biology of tumors will be important to either exclude cases or convert these cases from cold tumors to hot. So this is my summary slide. HCC is a growing problem despite successful HCV treatment due to increasing incidence of NASH and alcoholic liver disease. HCC from a management perspective is really two diseases, and hence it's a challenge to treat. And then one thing that is very relevant is that there is that liver cancer always happens in the background of chronic liver insult that happens over many, many years. And there is very important role of surveillance and early diagnosis, because that's where the surgeons can actually make a lot of difference in the treatment of these patients. And finally, a whole genome sequencing has allowed us to identify various molecular subclasses of these liver cancers that has allowed us to identify what drugs to give, but this is very much work in progress. And finally, the immune cell landscape of HCC needs to be worked in further detail so that we can identify the right patients to be treated by the right kind of immune checkpoint inhibitors.